One. Please start, sir. We are live.
A very good day to all who have joined us here. Myself, Dr. Vinod Kalkati from Medical Affairs team. On behalf of Zenith Division of Intas Pharmaceutical, I welcome you all of you for this edition of Endocrine Talk Show 2023. The main agendas of today's talk show is to review the current use of statins among Indian patients. And as always, to chair this session, we have with us Dr. Shubhankar Chaudhary, sir. He is the former head of the Department of Endocrinology at IGP-MER, IPGMER and SSKM Hospital in Kolkata. He is the immediate past editor-in-chief of Indian Journal of Endocrinology and Metabolism, past president of Endocrine Society of India, and immediate past president of Endocrine Society of Bengal. Dr. Chaudhary is the member of Subject Expert Committee for CDSO Government of India, a founder patron of South Asian Federation of Endocrine Societies, and in fact, he has more than 220 publications in various national and international journals to his credit. It's indeed really my pleasure to welcome such a stalwart in the field of endocrinology to this session. Very warm welcome to you, sir. Now, without any wasting further time, I'd like to hand over the session to Dr. Shubhankar, sir. Over to you. Thank you, sir.
Thank you very much, Dr. Vinod. It's a wonderful occasion this evening. Sorry, did I lose contact?
No, sir. Please go ahead, sir.
Oh, sorry. Yeah. So we are indeed privileged today to have amongst us two cardiologists, two endocrinologists, and a nephrologist. What better way than to have all of them around us when we discuss about something so very important as statin, which is widely used by one and everyone, but I suppose still it's not being used with optimum potential. So let's try and understand the uses, the abuses, the difficulties, the contraindications, the adverse effects, everything about statin this evening. And to take us forward, we have amongst us a cardiologist, Dr. Arun Chopra, who is very well known. He's director of cardiology at Fortis Escorts Hospital in Amritsar. And he has, of course, been a regular faculty in various national and international conferences, has many publications to his name. So that's from Amritsar. And then we have Dr. Shirish Shate. So now we move to Pune, who is Director of Cardiology at Dinanath Mangeshkar Hospital. Is again an excellent clinician, a wonderful person, and a great academician conducting DNP cardiology programs, and also has been part of various clinical trials. So from Amritsar to Pune, and from Pune to Kolkata, we have amongst us Professor Demalya Sannal, who is Professor of Endocrinology at the KPC Medical College in Kolkata and is also a visiting senior cardiology endocrinologist at different prestigious institutes and hospitals of the city. And he is also secretary of the RSSDI West Bengal chapter, has been involved in multiple international clinical trials in the field of endocrinology and diabetology. So welcome, Dr. Demalya Sannal. We also now move from Kolkata to Delhi now. So we welcome Dr. Priyanvada Tyagi, who is a consultant endocrinologist at Max Hospital, Patparganj in Delhi. And she is also director Hormone India, which is a collaboration of endocrinologists throughout the country. Great work, Priyanvada. And from Delhi, we move down to Manipal to welcome Professor Ravindra Prabhu, who is professor and head of unit in the Department of Nephrology at Kasturba Medical College at Manipal Academy of Higher Education. And he is, of course, has numerous accolades to his name, has published widely, is reviewer for several journals. So we indeed are happy and proud to have a rich faculty this evening. So my appeal to our audience is to make the best use of all of them, So shoot off your questions, and I suppose someone from interest will put them in the chat box, and I
Yes, sir.
can then address to relevant persons. So I don't see any questions yet. So let me start off with Dr. Arun Chopra. We all know statins are HMG-CoA reductase inhibitors. And we know that's a step in the synthesis of cholesterol. And so basically it blocks cholesterol synthesis and so should lower cholesterol level. So do you see the role of statins only or primarily as cholesterol lowering agent, or do you use it for its various other effects as well? That's just an opener for our evening's discussion. Yes, sir.
Okay. Good evening, Dr. Shubhankar. I think that's a good take-off point. See, statins have entered guidelines primarily because of their excellent capacity to not just reduce cardiovascular events, but also to improve survival. That means to reduce mortality. So in this regard, a large part of its benefit would be related to cholesterol reduction. However, we do know that we have a variety of drugs which lower cholesterol but don't have similar efficacy. For instance, we do not have a standalone survival benefit with any of the other cholesterol lowering drugs other than statins and to some extent PCSK9 inhibitors. Otherwise, we don't have this data for ezetimibe. We don't have, for that, we have event reduction but not survival benefit. And for the other drugs, like for instance, estrogen hormones, or we have drugs like torcetrapib, CETP inhibitors. So many drugs have been used, niacin, all of which could bring about similar or lesser cholesterol reduction, but did not actually have any survival benefit. Therefore, a large part of the effect would be related to cholesterol reduction, because we have data from Mendelian randomization studies. We know that people who basically have low cholesterol have low heart disease. So in that sense, yes, there is a correlation, but maybe we can say 3/4 of the benefit is cholesterol reduction, 1/4 of the benefit is other benefits. And perhaps one of the most important effects is the anti-inflammatory effect. If we look at Jupiter's study, which took patients who had no evidence of established CAD and who had an elevated CRP, which indicated a somewhat inflammatory milieu, in those patients, the use of rosuvastatin over a couple of years brought on not only event reduction, but also survival benefit. So I would say large part is due to cholesterol reduction, but not all. And pleiotropic benefits would also have some role, which is why statins is number one, and rest everything is below that.
Right. Can I put forth a very naive question? Maybe Dr. Chopra yourself. So when we say anti-inflammatory property, so can we use statins for inflammatory arthritis?
There are a lot of conditions for which statins have shown positive effect. For instance, we have heart failure with preserved EF, where it's not class 1 therapy, it doesn't bring about survival benefit, but we have data to show that there is event reduction, which is, I'm not saying it is entirely an inflammatory effect, but statins have acted at several other places where cholesterol reduction does not seem to be the mechanism of action. In fact, till about 20 years back, surgeons used to stop statins prior to surgery. I mean, I'm talking about bypass surgery. Cardiac surgeons would stop not just clopidogrel or Disprin, they would also stop statins prior to surgery because they felt that the patients who were on statins bled too much. So there is a possible anticoagulant effect as well. So there seem to be a lot of other effects. The startling anti-inflammatory benefit which we are talking about is that we know that there are two parts to atherosclerosis. One is the part of, silent atherosclerosis or maybe stable coronary artery disease, and the other is the precipitation of acute coronary syndromes, where we are looking for not just a vulnerable plaque, but a vulnerable patient. And this inflammatory milieu seems to be a factor which precipitates ACS. Statins seem to lower that inflammatory milieu and hence lower the risk of getting an ACS. So that is probably how statins act in addition to their lipid role as well.
Right, great. And I hope there aren't sort of two opinions about this amongst the other panelists this evening. If there is, you can come up. Yeah, Dr. Shili. Always
Yeah.
cardiologists will have different opinions.
Opinion. No.
Okay.
I think only high dose statin has got, one can say, anti-inflammatory in acute coronary syndrome, where they can cause plaque stabilization. But I'm not sure whether 10 milligrams of atorvastatin will have anti-inflammatory. And I personally feel that I'm a bit skeptical about so-called pleiotropic effects. He rightly said that 20 years ago, it was tried in everything. It was tried for gout and whatnot, and arthritis, etc., etc. But I think it was kind of hyped that the whole pleiotropic effect of statin was a bit of a hype at that time. It has some effects beyond just lowering of cholesterol, no doubt about it. But I would say that they are there at the very high dose statin.
Yeah, I suppose that's accepted by all. And I'm really thankful to our audience that they have started putting in questions in the chat box. My only appeal is please put short questions, small questions, sharp questions, because I have to go through details and then address to our panelists. So please put short questions. So first one, Dr. Shili Shathe, is for you. Are there any evidence of adverse effects of extremely low LDL cholesterol? Less than 10 is a specific figure, but let's take it on a general level. And cardiologists in general are very enthusiastic at keeping the LDL as low as possible. And sometimes we endocrinologists crib that no, cholesterol also has a physiological role. You can't bring it too low and so on and so forth. So what is your view?
Yeah, I mean, that was a concern when PCSK9 trials were started and when the LDL started going down to almost 20. And initially, it was thought that it will have some cognition effects. But it has been found out that there is no really cognitive dysfunction, even when LDL goes down to 20. I don't know what is safe LDL, but when in a newborn baby, the levels of LDL are between 25 to 30. So I think 25, 30 is enough. And so that we can certainly go down to 25, 30. There is no doubt about it.
Right. Thank you. Yeah.
That is the safest level, I would say.
Sure.
Yeah.
Good. And now can I turn to our endocrinologist colleague, maybe Dr. Demalya Shandal. So you and I see a lot of patients with diabetes, so do the cardiologists and even nephrologists, of course. So what would be the indication of a statin in a type 2? And if we can differentiate, is it means the threshold for starting a statin, is it different between an adult and we have got adolescents, even children with type 2 diabetes? So are the levels different when you start a statin?
So, sir, as you just pointed out that with different population, if we can start with the children with type 1, because that is very less often discussed. Because generally the guidelines says that we need to at least test for the LDL cholesterol once the glucose and the lipid profile has to be assessed after the glucose is controlled and after 2 years of age in type 1 diabetes. And then we need to see what's the level, and if it is normal, we can reassess after an age of 9 to 10 years and then 3 monthly. So in children, especially in type 1 diabetes, still it is, though the cardiovascular disease sets in pretty late, there is no milieu of other metabolic risk factors, but it is still associated with significant cardiovascular risk as well. And what is recommended is specifically after the age of 10 years, generally below 10 years, statins are not recommended in type 1 diabetes. And we generally, the recommendation is first is to start lifestyle for at least 6 months. And then if the LDL is more than 160, we can start a statin. Otherwise, if there are additional risk factors with the LDL cholesterol of 130, we can also start a statin as well. Whereas in type 2 diabetes in young, which we are seeing much more commonly nowadays, a lot of patients come at quite an early age because of the obesity pandemic. So there, basically, the risk factors are actually higher, not only compared to type 1, but even cardiovascular, both macro and microvascular risk factors are actually even higher than type 2 diabetes, the adult type 2 diabetes. So the progression is much faster as well. So there, we need to assess once the glycemic control has been achieved, and we can actually, if the LDL cholesterol is more than 130, after lifestyle modification for 6 months, then we can start a statin as well. And generally, though the ADA recommendations suggest after the age of 10 years, we have the ISPAD recommendation, the International Society of Pediatric Endocrinologists, where their recommendations even start at the age of 8 years as well in type 2 in young. And finally, in adults with type 2 diabetes, generally after the age of 40, irrespective of LDL cholesterol, what we have from the different trials is that we can start irrespective of cholesterol, because any reduction in cholesterol will improve cardiovascular outcome. But obviously, in type 2 diabetes in elderly, we generally go for a moderate dose, as in adults who do not have high risk factors. But patients who have established cardiovascular disease, obviously we need to go for high intensity statin and need a reduction of at least 50%. So that is those who have established cardiovascular disease, we go for a higher intensity. But in majority of our patients, as you rightly said, sir, that we generally go for who do not have established cardiovascular disease, we go for a moderate intensity statin, that is about lower dose of statin, rosuvastatin or atorvastatin, what we have. Only in a few subjects we go for a higher dose.
Right. And we do have quite a few more questions, but some of them are related to triglycerides. I do understand the importance of looking at the lipids overall, but if we do not answer some of those questions, it may be because we didn't have time to cover it, because primarily we shall be discussing statins this evening, but we shall try and accommodate the questions as well. Now, can I turn to Dr. Prangbada Tyagi, young endocrinologist? So we have a young lady, 30-year-old IT executive lady, who is recently diagnosed to have type 2 diabetes, which is quite common these days to see at those ages. And she has also got an LDL of 125. Dr. Devandrashannan did say that if it's 40 and above, then you should straight away start on a statin. So this is not 40 yet, and a lady. So do we start her on statin with the LDL of 125, recently diagnosed type 2 diabetes?
Okay, good evening, sir. So, sir, first of all, if I talk about the age, now age is a very important factor when we calculate the CVD risk. So at the age of 30 years, 10-year risk is not very high, but because the duration of diabetes is going to be long, the long-term risk of any CVD event is going to be high for such a patient. Now, coming to LDL cholesterol level of 125. 125 by itself in a young patient is not very high. So in this person recently diagnosed with diabetes, I would advise very stringent lifestyle measures, a good healthy diet and regular physical activity. And after 3 months, we would like to repeat a LDL cholesterol level. If it comes to less than 100, then I would continue the lifestyle changes. If not, it is advisable to discuss the pros and cons of a moderate intensity statin, but not right away.
Right. At this age, I would believe that one should also discuss about pregnancy planning.
Yes.
So, if she is planning pregnancy in the next 6 months, so what do we do? So, do we start on statin, or what do we discuss then? Or do we
No, sir,
start?
not even then. I think she has type 2 diabetes. It also relates to the degree of glycemic control. If we get her blood sugars under control, if we, she does very good lifestyle interventions, then I think it should be okay.
Right. But with blood glucose control, do you expect the LDL also to come down? Let's
I guess
assume
right
that
more, but
glucose is-
to some extent LDL as well, sir.
May I add just a couple of quick comments with your
Yeah, of
permission?
course. Yeah, of course.
One is if a lady is anticipating, I mean, if she's planning a pregnancy in the next 6 months or is pregnant, statins are contraindicated at the moment. So in such a patient, we will obviously not give statins. That is just an important issue.
Right. Yeah, absolutely. So we have introduced Professor Ravindra Prabhu. Haven't heard him yet. So let's get him up front. So let's talk about statins in CKD. There are guidelines which suggest that if someone is already on a statin and has gone into end-stage renal disease, then you continue with the statin. But you don't start someone who's been diagnosed to have dyslipidemia and is in CKD, at least end-stage renal disease. So what are the issues in relation to the use of statins in CKD? And what would be the indications? And is there maximum dose that we can use statins, or do we need to dose modify in CKD? Some of the issues if you highlight.
Good evening, sir, and thank you for having me on this August panel. Just to introduce the chronic kidney disease, we diagnose anybody with a kidney problem which is has impact on the health which lasts for more than 3 months. So this could be in the form of urinary abnormality like presence of albumin in the urine, or somebody who has parenchymal changes on the ultrasound, or somebody who has had a formal kidney biopsy or has had a kidney transplant, or simply someone who has a comorbidity and who has an estimated glomerular filtration rate, which we measure using chronic kidney disease epidemiology, that is the CKD EPI formula. It's a calculator which is available on the net, and the normal GFR will be 90 to 120. So somebody who has a marker for kidney disease or who has an eGFR of less than 60 ml per minute, we consider as chronic kidney disease. So basically, this is a silent problem.
Can
And
I
yes,
Dr.
sir.
Prabhu, yeah,
Yes,
sorry. Can I just interrupt and ask you? Everyone has his or her own favorite formula for calculating eGFR.
Yes,
For
sir.
example, I love the MDRD, and you only said CKD EPI. So is there much difference between these?
Actually, sir, to tell you the truth, none of these formulas have been validated in our population. These are all US or European-based formulas. And till recently, they were also having a racial kind of differentiation. That is, they used to have corrections for blacks. And what we used to apply was the formula for the Caucasians. And the old formula was the Cockcroft-Gott formula, based on which the dosing was given for most of the drugs. But what is recommended now is the CKD EPI. This is simply because the CKD epidemiology formula has been validated across the both the normal, the CKD, and in transplant population. Whereas that MDRD formula is mainly in the patients who are in CKD, that is below 60. It has been validated. In the upper levels of GFR, it has not been fully validated. But be as it may, the differentiation may not be much between the two formula. And only in somebody who's on the borderline. For example, in one formula, he comes to be 58, on another, it would be 62. So in that situation, so it's more of an epidemiological kind of differentiation. In the day-to-day clinical scenario, it may not make much difference to the patient as such.
Sorry for that interruption. Please go ahead.
Yes, sir. Now, regarding the use of the statins, basically, the chronic kidney disease is considered as a risk-enhancing factor. It is not considered as an actual risk for cardiovascular disease. However, there is a difference in opinion, and some people would say that it is equivalent to a diabetes as a risk for this cardiovascular disease. And basically, of course, that applies to patients who are in advanced CKD, where you start seeing the creatinine going up. And that definitely, as the CKD advances, the risk goes on increasing. In fact, the risk for cardiac disease would be 10 to 100 times that in the general population. So any patient who is having a low GFR below 60, we could start them on a statin. And if the glomerular filtration rate is more than 60, and if his age is more than or equal to 50 years, then we would again start the patient on it would be an indication to start the patient on statins. This is for the primary prevention. And
Sorry. Irrespective of the lipid level, if someone's eGFR is above 60 and
Yes,
someone
sir.
is above 50,
Yes, sir.
he or she should be started on statin.
Yes, sir, because
Is that
they
the
would fall
message?
into that risk for development in the next 10 years for chronic, this atherosclerotic cardiovascular disease. And of course, as a secondary prevention, if the patient also has other CVD risk factors, that is like, for example, if he's having diabetes mellitus or hypertension, he's a smoker, or the HDL cholesterol is low, or if you have measured the lipoprotein A, then if it is high, and that situation, of course, that would by themselves be indications to start this thing. Again, I would like to mention that most of the chronic kidney disease is caused by diabetes mellitus. Almost 40% of the patients of CKD, it's due to diabetes. Another 20-30% is due to hypertension. And the other classical kidney diseases would form, like the hereditary kidney diseases, and others would form a lesser chunk of the chronic kidney disease population. And if you want to be really strict about it, then there would be calculators which would measure the absolute risk. And if the risk is more than 7.5% or higher, then we would start the statins. In between 5 to 7.5, it's a judgment issue. And below 5%, that's the recommendation that we would not offer the statins to these people unless there is a real other indications to, or the patient already has some coronary disease or cerebrovascular disease or peripheral arterial disease, then we would be giving it. Regarding the dosing, there is some concern about adverse effects being more. I don't really know whether that has been tested. So the moderate intensity statin would be given. For example, atorvastatin we would give at approximately 20 milligram per day. So this is my take on this. I'm open to questions, sir.
Can I make a comment?
Yes, sir. Yeah.
I think at this point of time, we should also introduce the targets, different targets of LDL levels. And there are 4 different targets of LDL level, depending on the category of the risk. So one has to do risk stratification of a patient to decide the target. So if it is mild risk, and there are definitions of mild, moderate, high, and very high risk. If it is a mild risk, the target is 115 LDLC. If it is moderate, the target is 100. If it is high risk, target is 70. And if it is very high risk, target is 55. So it doesn't matter what is, whether it is a moderate level of statin that you give or a high dose of statin. You have to treat to the target. And when, as far as CKD is concerned, if a patient has got established ASCVD, and if he has got a moderate CKD, then he becomes high risk. So the target becomes 70 for him. If he has severe CKD, the same patient will become a very high risk. So the target changes to 55. So the target changes. There is no doubt that CKD now is considered as a risk enhancing or almost a risk factor for coronary disease. So the target changes, that is all, depending on the level of CKD.
Right. So there has been some concerns with statins, especially rosuvastatin. I believe that it can cause proteinuria. So what would be the nephrologist's take? So, and we have got some questions in our chat box, which we will come to soon. Is there any differential choice among statins in presence of CKD? One statin is better than the other. For example, pitavastatin is stated to increase GFR or something like that.
Yes, so the preferred statin would be atorvastatin, and the rosuvastatin is supposed to be more potent. And basically, we prefer to give the atorvastatin simply because it's more available, and there is very less renal handling with that. So we don't expect the dose to be changed, and the concern will not be there. Of course, if the patient has additional morbidity like hypothyroidism, or he's on this cyclosporin, then again we need to have more monitoring for these patients. But otherwise, that would be the one which is this thing. And as you very rightly said, sir, that there is some concern that this rosuvastatin may be associated with some hematuria, and also this small molecular weight proteins, because it blocks, means it increases the excretion of small molecular weight proteins. But these are not of considering the high risk of cardiovascular disease. These may be of lesser concern, because basically we need to prevent or treat the heart disease first.
Right.
So may I make a comment here, a small comment, Dr. Subhankar?
Yes.
I just wanted to add a couple of points. One is the fact that there is a small study comparing rosuvastatin 10 mg with rosuvastatin 40 mg in patients with eGFR less than 60. And the result was that 10 mg did not have so much effect, but 40 mg reduced the eGFR further. And so high dose rosuvastatin is not desirable in CKD. The other thing is, as Dr. Saab just mentioned, that atorvastatin is preferable to rosuvastatin in established CKD. The third thing is that the latest ESC guidelines on prevention of CVD, I mean primary prevention, now reinforce that if there is established CKD with the eGFR less than 60, then we should preferably not start with high dose unless there is a clear event. So for primary prevention, we should start with a low dose of atorvastatin and then step up based upon response, its safety, and other issues. And we should not directly start with high dose statin in CKD unless there is an ACS.
Right. So we will come down to the question that we have in the chat box. Now, my observation has been it's not properly done study. By and large, cardiologists tend to prefer rosuvastatin. Maybe it started after the Jupiter study or whatever, or because it's so effective, because more potent than atorvastatin. Maybe endocrinologists prefer atorvastatin. Maybe not. But what is your opinion? Can we have Dr. Shirish Sathe first on atorvastatin versus rosuvastatin? And our member in the audience specifically mentions the latest presentation of Lodestar in the ESC Congress only very recently.
Lodestar. I was actually coming to Lodestar only.
Yeah,
I have been using atorvastatin almost in 99% of my cases. Only if a patient is already on rosuvastatin, I will continue. But till today, there is no evidence or head-to-head trial to say that rosuvastatin is superior to atorvastatin in terms of clinical outcomes. And the Lodestar trial is one of the first trials of significant size, which was presented at recent ESC a couple of weeks ago, which also showed the same thing, that rosuvastatin is non-inferior to atorvastatin as far as outcomes are concerned. So whether one uses rosuvastatin or atorvastatin doesn't make any difference. I am still sticking with atorvastatin, and I think that is okay. I'm not doing any disservice to the patient. It is, right. Yeah. Both are
Arunji?
So I entirely agree. I preferably use atorvastatin because see, atorvastatin has all the data for secondary prevention.
Exactly.
When
Exactly.
rosuvastatin was started, it failed in all secondary prevention trials. Then they had to create a new indication. So they looked for this Jupiter indication, which is sort of normal lipid levels with an elevated CRP, where rosuvastatin was useful. So rosuvastatin has data only in primary and not in secondary prevention. So my go-to drug by far is atorvastatin. Rosuvastatin also has higher side effects. If we look at any side effect, whether it is myalgias, whether it is hepatic dysfunction, whether it is CKD, everything, peripheral neuropathy, everything is more in rosuvastatin. My choice is therefore atorvastatin.
More
I think
diabetogenic also, sir. Rosuvastatin is more
Yes,
diabetogenic.
The HbA1c rise is some points higher with rosuvastatin than it is with atorvastatin. So for all these reasons,
I think rosuvastatin.
Even the Lodestar study also found out that the diabetes
Yes.
incidences were higher, as well as the cataract incidences were higher. There was no difference in the outcomes.
No
So,
difference. So I think
probably-
rosuvastatin was sold on the basis of Jupiter trial for primary prevention, and then it was extended to secondary prevention without any evidence for it. And
Okay.
Jupiter trial itself is a kind of a defective trial. So I
Right.
never used rosuvastatin.
Okay.
very
So,
well
so,
taken. Very well
so,
taken.
so I take back my statement that cardiologists prefer rosuvastatin. I take back because we have got two representative cardiologists here. But so that brings us down to a question in the chat box. How common is statin-induced type 2 diabetes in your clinical practice? How do you manage such cases? Maybe because the cardiologist will be treating more non-diabetic individuals with statins, so they may have a better feel of this. So any of the cardiologists, maybe Dr. Shirish, so how common do you think?
In a non-diabetic patient
Yeah, statin-induced diabetes.
or statin-induced. Yes.
Yeah.
Okay. Actually, I mean, there's a lot of
We
discussion
don't
about
need specific figures, but just an idea. Yeah.
the incidence is very low. First thing. Secondly, it is seen in a very high dose statins, the 80 milligrams of atorvastatin or 40 milligrams. And there was a third school of thought where people started thinking that these are the patients who were anyway going to develop diabetes. So it is better to give them statins and continue giving them statins. So these are kind of higher risk patients anyway. So continue with statins. But fortunately, the problem is a small problem, really.
Right.
In a day-to-day practice, we don't see it because we don't use 80 milligrams of atorvastatin.
Not long term, right? So
yeah, except ACS.
Yeah. So once we start someone on a statin, whatever the indication, whether secondary prevention or primary prevention. So what is our expected biochemical improvement in terms of LDL? How much LDL do we expect to come down? And can I also ask what happens to HDL? Because all the what do you call them? The product inserts, they would suggest that they also increase HDL, maybe a small amount, but in my practice, I must say that almost invariably I have seen as the LDL comes down, the HDL also comes down. But that's not what's there in the product insert. The LDL HDL ratio, of course, improves. But so maybe can we have Dr. Arun Chopra enlightening us on this? And also about triglycerides, what happens to them?
So I think that's a very important point, and it is very well taken that LDL reduction is of course proportional to the dose. So you can aim for 30 to 50% or more than 50%. You may or may not achieve it, but we know that high dose statin tends to achieve 50% reduction, and moderate dose at least more than 30% reduction of LDL. HDL, I would agree. Rarely do I find people who have higher HDL on statins. LDL over HDL ratio improves markedly, but HDL per se probably comes down. And since the total cholesterol to HDL ratio doesn't worsen, and since the LDL to HDL ratio doesn't worsen, it actually improves. Therefore, statins continue to have benefit. Triglycerides, there is a marginal reduction, maybe 10 to 15%, which is somewhat more with rosuvastatin than it is with atorvastatin. But they are not the drugs of choice really for triglyceride reduction. We give them first for reduction of ASCVD risk. And triglycerides we handle later, of course, depending upon the levels and risk factors. As you know, if it's more than 500, you would consider adding a fibrate. But if not, then you would go more for lifestyle management and start fibrates, or we have icosapent and ethyl, which is also available now in India, but very expensive and hard to get. We would start that in select patients. But otherwise, this is what a statin would do.
Right. So,
Can
we
I-
talked. Yes,
Yep.
yes, sir. Yes,
Yeah.
sir.
One thing is about HDL, and this is a very practical problem. As you have rightly said, patient comes with a report, and he's not worried. He's not happy that LDL has come down. He's more worried that HDL has gone down, and he will tell you that my HDL has gone down so much. Do I have to worry about it? Luckily, now most of the CEPT trials on HDL are negative. So I tell my patient that don't worry about HDL. We don't look at HDL now. So that is what I tell the patient.
Shall we now discontinuing? I mean, this is my practice that I do say this is a good cholesterol, that's a bad cholesterol. So shall we stop branding HDL as a good cholesterol?
As a good
Shall we stop
cholesterol,
it?
because raising HDL hasn't shown benefits.
No,
At least not with CETP inhibitors. There are other trials now, other molecules which are coming up. But as it stands today, raising HDL doesn't improve benefits. And about triglycerides, the best drug today for triglycerides is still statin. Statin is the first drug that you have to use if you have to get triglyceride down.
Yeah, but how much does it lower triglycerides by? Statins, I mean, if you use 80 milligrams of atorvastatin, will it come down very significantly? I mean, is that an experience? I mean, I
No,
somehow don't feel so, but that's the recommendation that you first use statin.
That's right. So if it doesn't come down, then you add other things, fibrates.
Right.
That is the recommendation, the ESC recommendation.
Yeah,
You
I
start
know,
with
sir.
statins and then add on fibrates if it doesn't come down.
Just a point here, Dr. Shubhankar. Here, I would tend to disagree a bit in this regard. Triglycerides actually tend to rise with high dose statins. And
Okay.
even though it's recommended that you start with statins,
Yeah.
and we do, I entirely agree. This is what we do. I said that also earlier. But you will find patients where if you come down from 40 to 20 with atorva, you'll find their triglyceride come down 10, 15 milligrams. And that may be in part because you reinforce lifestyle, that may be in part because you reduce the dose of statin. But broadly speaking, triglycerides don't come down too much. 10 to 15% is the maximum they will come down. And especially if they are more than 450, they will not come down with statins. So that I think we need to recognize.
Right. So can I ask Dr. Priyank Bada? We have been talking about atorvastatin, rosuvastatin. And my conventional advice has always been to use statin at night, at bedtime maybe. So is there anything very important, critical that we advise, give a specific timing for taking statins? Or does it matter between atorva and rosuvastatin?
So, sir, why we usually prescribe it at night? Because the HMG-CoA reductase activity peaks at night. So the cholesterol synthesis physiologically is highest at night. So we usually prescribe it at night. Now this arises more with the shorter acting like simvastatin. When we prescribe atorvastatin or rosuvastatin, which are the most commonly used ones, timing doesn't really make a difference. But as a standard, I think everybody prescribes them at night.
Right. Okay. And Dr. Sanyal, so we heard about different statins. Do you have any basis for selecting among the different statins? For example, something one is water soluble, the other is lipid soluble. So, do we need to consider all of these before deciding which statin to use?
Sir, at this point of time, at least with the level of evidence and the availability of the major statins which we have, mainly we are using rosuvastatin and atorvastatin primarily because the high intensity statins are basically rosuvastatin and atorvastatin, because there is no other high intensity statin which we can use other than these two molecules. So in patients for secondary prevention, there is no other option. Well, we now have the studies suggesting that there is actually no difference with regards to cardiovascular outcome between rosuvastatin and atorvastatin, though even that study found out that there is slightly more LDL reduction, but that did not translate into significant benefit with regards to cardiovascular outcomes. Now, with regards to statin, again, if we look at the lipophilic and the hydrophilic statins, out of those available in our country, if we see atorvastatin is more likely to be lipophilic. So there are some, issues again which are not really convincing. Evidences are still not there regarding any risk of memory or cognitive impairment, which may have an atorvastatin is more theoretically likely to have a more impact on cognitive impairment, which probably these molecules are less likely to have impairment. And also we have agents like the pitavastatin as well, which may be probably a little bit lipid friendly. With regards to GFR, it may be more preferred. And in patients with CKD, just like atorvastatin is probably more preferred in CKD. So in certain patients, probably we would be choosing. And again, in some patients, probably when we are looking into statin intolerance with one group of statin, when we exchange that to, because prior to establishing statin intolerance, we need at least to have tested 2 statins, then we can change it. And especially if we look at it, we can try with a lower dose of probably rosuvastatin in such a population as well, where we can start with a lower dose of rosuvastatin, or even especially if patients are having some transaminitis with raised transaminase, where we need to start with a lower dose, then probably even a pitavastatin at a dose of 1 or 2 milligram may be preferred. So in general, there is probably in the patients for secondary prevention, there is no difference between atorva and rosuvastatin, but in certain population subset, we may choose statins which may be more suited for that particular patients depending on the comorbidities.
So in elderly patients, pitavastatin could be better because drug interactions are a little less.
Okay, fair enough. So we all use statins primarily for cardiovascular protection, but when we talk of cardiovascular, we primarily think about cardiac protection. What about ischemic stroke? What about peripheral arterial disease? What is the evidence, if any, that statins also help the central nervous system, means strokes and peripheral artery disease? Dr. Chopra, would you like to take that up?
So basically what is established is that the total risk of events is actually more in those who have non-cardiovascular disease. That means the actual risk, the actual atherosclerotic risk is higher, and the risk factors are more maximum in peripheral vascular disease and somewhat lesser than that in ischemic stroke patients. So these are also extremely high risk patients. And though the data is not as much, for instance, we have data to show that 1 millimole reduction of LDL brings about a roughly 20 to 25% reduction in CAD. The data is somewhat lesser with the other two vascular diseases. So with peripheral vascular disease, it is approximately 20%. And with stroke, it is approximately 10 to 12% reduction of ischemic stroke. In stroke, we also have the caveat that there seems to be some increased risk of intracerebral hemorrhage, but which hasn't turned out to be statistically significant. So, taking all this into account, the current guidelines on primary prevention of ASCVD recommend statins not just for prevention of MI, but also for prevention of stroke and prevention of peripheral vascular disease. And all patients with established stroke, which means ischemic stroke, or ischemic gangrene or peripheral vascular disease, equally well deserve a statin, because they are actually, polyvascular patients are actually at higher risk of mortality than simply coronary artery disease.
Absolutely. Thank you. So one of the questions that patients will always ask whenever you start on any drug is how long to take. So would Dr. Shirish Sate answer this for our patients? So how long should I continue on statin? And secondly, what are the hazards of stopping statins?
Yeah, I think that's a very good question. Unfortunately, in medicine in general and cardiovascular disease in particular, there are no cures. There are very few cures in cardiovascular medicine. And similarly, high LDL levels, there is no cure. It is only control. And that actually translates into a lifelong statin therapy for all patients. So how long? The duration is lifelong. The answer, I think, is simple. You can reduce it and treat to the target, but whatever at that level, you have to keep giving it for lifelong. Are there any rebound effects? Yes. If you stop high dose, especially high dose of statin, suddenly in a patient who has acute coronary syndrome, they have shown that there is increased risk of getting myocardial infarction as well as death. But even otherwise also, you should not try and stop statin suddenly. You should taper off and then stop or change over to some other statin. So rebound effect is known, more pronounced with very high dose and in acute coronary syndrome subset.
So it's very clear-cut answer. It's lifelong treatment essential unless there's specific contraindication or whatever problems arise. Right. So can I ask you one more question, because that's there in the chat box? Please share your experience of effect of statins on LP little a levels.
Yeah. So lately now LP little a is becoming HDL of 10 years ago. So every research is now on LPA because there is no evidence for HDL. Unfortunately, there is no medicine till now available which will reduce LPA. And although there are a couple of molecules which are in trial now, but there is no medicine that is available. So statins have very little effect on LPA.
Actually, there is some trial data to show that statins actually raise slightly the levels of LP little a. So they are really not recommended for this. PCSK9 brings about some reduction in LP little a levels, but we are getting antisense oligonucleotide, hopefully.
Antisense phase 3 trials are on. So phase 3 trials are still on. So we will get the answer in a couple of years.
Right. So can we come back to Dr. Ravindra Prabhu regarding the adverse effects of statins? First of all, how common are they, and what are the adverse effects of statins? Please unmute yourself.
Yes, sir. As a nephrologist, we are really concerned with the adverse effects because the toxicity is a concern. But considering the large-scale use, they may not be that common. As a symptom-wise, the muscle-related symptoms, that is the myalgias, they seem to occur in approximately anywhere between 1 to 10%. And some of this may be related to the popularity of these drugs. What is called as a nocebo effect. That is, these people look at these drugs in the media That is the non-medical media, and they read about it, and then they seem to get these things. The other really concerning effects like the myopathies and the actual rhabdomyolysis causing an acute kidney injury, myonecrosis, these are fortunately very less common, maybe anything less than 0.5%, I would say. And as of my experience with the statin-induced acute kidney injury is just anecdotal. I can say anecdotal. Of course, if it is the patient is an alcoholic, he's taking alcohol regularly, or there is a hypothyroidism, or it's a transplant patient or a person who's on immunosuppression, like calcineurin inhibitors, like cyclosporin. So these are the people whom we would be really looking for that. And basically, our guidelines, what they say is that we just treat and forget it. But when we start the patient on the statins, we would definitely do a baseline transaminase levels and the creatine kinase. And if that is normal, and we would start, and then we would not really monitor the creatine kinase or this thing if it was initially normal. Of course, if the patient has the symptoms like myalgias and all, that time we would monitor it. And if, of course, if he's on the other medications like the CNIs, or if he's hypothyroid, then of course we would maybe monitor that.
Right. So can I ask the cardiologists, how common is statin intolerance? Because I find it very uncommon, but you would be using the higher doses more often than I do. So how common is it?
So there is, if with your permission, I can start off, and I'm sure Dr. Sathe will have more to add. There is a ACC statement on statin intolerance, and though the number of people who, as Dr. Prabhu was saying, who complain of muscle aches is more, it's probably 1/4 or more of the patients on statin. Many of them, when you stop statins, they don't have relief of symptoms. They actually continue to have symptoms. So it is not entirely clear that all the pain which they have is due to statins. So the ACC statement mentions that about 10 to 15% individuals have statin intolerance. And I would agree that that is probably roughly the number of patients which we see. The subjects who have more of this are the older patients, the patients who are also on an associated fibrate, the patients who have CKD, and patients who have thyroid hypothyroidism. These would be the patients who actually have, who are more likely to get symptoms. Otherwise, I think the large majority, at least more than 80%, tolerate the doses of statins we give them reasonably well in order to reach the target doses of LDL, which Dr. Sathe just mentioned.
So in Amritsar, you have 10 to 15% of patients complaining. So what about in Pune? More. Okay.
Pune.
Okay. Pune.
See, statin intolerance is because of myalgia, but there is something called as perceived myalgia and actual myalgia. And perceived myalgia is much more than actual myalgia. Yeah. So when you measure CPK and find out that it is actual myalgia, the percentage given is varying, but it is around 9 to 10%. In my practice, I see it even less. I mean, I'll go with you that I see it very uncommonly, really. Not because of myalgia.
Yeah, so that's what. So do you need to stop statins because of the side effects? How often does it happen? And then the question will arise, what else do you use if you can't use statins then? Bempedoic acid today, ezetimibe today.
Yeah.
Okay. Yeah. Right. Okay. So can I ask Dr. Priyangada? So because of this, whatever perceived myalgia or whatever, there are a few brands of statins in our country who have come along with the vitamin D. So does it help? Vitamin D, will it help to prevent? And the other question would be about CoQ. So it is suggested that it's all because of CoQ being low. So if you supplement CoQ, then the symptoms go.
So, sir, but it is considered that because of the CoQ levels go down, that is why you have myalgia. There are a lot of combinations also which are available, but studies have not shown a significant improvement in myalgia by either adding CoQ or vitamin D. Now, vitamin D deficiency, if it is there, then treating it would help. But I have prescribed it in one patient just to take to get an idea, but I don't think it helped. Just reducing the dose of statin actually helped, because whatever minimum dose you can give, you have to give.
Right. Yeah.
But
Okay.
I don't think the other two didn't help, and there's not a lot of evidence also to say that.
Right. So we are nearing our allotted time, or maybe we have just reached the allotted time. But let's try and continue for a little while more. And you would all be happy to note that more than 1,000 doctors have already logged in to listen to your pearls of wisdom. So can I ask Dr. Demandra Shannan, as we are trying to wind up gradually, so what would be the contraindications to the use of statins? Absolute contraindications, relative contraindications, are there any?
Yes, especially absolute contraindications would be one, in patients where there is decompensated liver disease or acute liver failure. That is one absolute contraindication. Again, if patients runs into rhabdomyolysis, again, at that point of time, at least still resolution, one shouldn't be using it. And obviously, as we have also previously discussed, is during pregnancy and lactation. So that also are two are absolute contraindications. Though recently the FDA has actually allowed use of statin, especially in very high risk subjects with cardiovascular disease, as well as in patients with familial hypercholesteremia, especially because of the fact that as far as evidence which has come up, especially that doesn't suggest any fetal anomaly or any long-term effects, both in the fetus or mother, or even any fetal death as well. So that is something, though one should not be using it, it's still contraindicated, one should not be using it, but in very high-risk conditions, like patients who are already on statins because of familial hypercholesteremia or established cardiovascular disease, one can continue. Otherwise, for pregnancy, lactation, decompensated liver disease, and acute liver failure, these are absolute contraindications. Rest are just we were discussing, like myopathy or liver transaminitis elevation beyond 3 times. We may discontinue. These are relative contraindications like absolute. And again, whatever evidence, even the RCTs do not have any data with regards to CoQ10 or with regards to vitamin D in terms of really improving the outcome or mitochondrial bioenergetics.
Right. Great. So maybe the final question, Dr. Arun Chopra, where do you see the use of these other lipid-lowering agents like ezetimibe, bempedoic acid, PCSK9 inhibitors? These are the ones which are available to us, are antisense oligonucleotides and all, not yet available. Are they available to us in our country?
No.
Right. So what would be the indications for them? Are they with statin, or when you have statin intolerance, then you use them? Quick words.
Okay,
Yeah.
so to answer it quickly, statins are the backbone. Ezetimibe I would use in people with established ASCVD, where we are unable to achieve target LDL levels with high dose statin or the maximum tolerated dose of statin. In patient,
can I sorry interrupt and say what
Sure.
proportion of patients would actually need on that indication?
So I don't think I use in more than 10%. I would be using in less than 10%, even though there is now a move to start statin ezetimibe combination in all patients who have had an ACS, but I am yet to follow that. I will still continue with high dose statins and use ezetimibe in those in which I am not able to achieve the goals. PCSK9 is again for the same indication. If after statin and ezetimibe we can't achieve the goals, but availability, cost, and inconvenience are all issues, and therefore I have very few patients on PCSK9. Bempedoic acid I have started selectively, but it's only started in the last 6 months or 1 year, and therefore I don't have enough data to really tell you, but I have started it anecdotally. Maybe I have a few patients, handful of patients.
So where
Be
would
able
you
to give you
use?
personal.
Yes.
Where would you use the bempedoic acid? Matlab, in which patients do you use? Because I don't think we've ever used.
Bempedoic acid has one clear indication. It is indicated for patients who have statin intolerance. So like we discussed, about 10% patients have genuine statin intolerance. They are the patients in whom you can start with bempedoic acid. And if you don't achieve the goals with those, because you will achieve about 18 to 20% reduction of LDL with bempedoic acid, you can add ezetimibe. With ezetimibe, the efficacy comes to about 35% LDL reduction, which is the same as moderate intensity statins. So these would be the patients with clear evidence of statin intolerance, where you would give bempedoic acid.
But not saroglitazar, sir, here?
Saroglitazar has
I think for
no
diabetes,
data
matlab, we feel that it helps with the diabetes also, and
it
little
does
bit.
help, no doubt. But saroglitazar, one problem is you can't use high dose statins with it. High dose statins is a problem. Whereas in patients who are very high risk or high risk, we would prefer using high dose statins, and most diabetics would fall in that subgroup. And I believe personally that most of the benefits of saroglitazar can be achieved with lifestyle management. I am a big proponent of exercise and diet control. I would, write a lot about nutrition. So I think most of the benefits of saroglitazar you can achieve.
Yeah,
And saroglitazar doesn't.
With regards to bempedoic acid, one benefit is, you have the clear outcome data now showing cardiovascular benefit outcome. And secondly, even in diabetes patients, more importantly, bempedoic acid improves HbA1c, prevents new onset diabetes as well. So there can be some improvement, though it may be more theoretical. So
yeah, but right now, clear outcome is only for intolerant patients.
Yeah, it's only for statin intolerance.
Only statin intolerance. About ezetimibe, I use ezetimibe very generously. Majority of my patients are on combination. And I think lately people have been advising upfront combination therapy like we do in hypertension. So start with 2 molecules upfront. That is the trend now. And in addition, one more trend, one more thing that one more new term has been coined is the LDL pack years. Like we talk about smoking pack years, there is LDL pack years. So the exposure time of high LDL is as important as the actual LDL level. So catch them young, especially diabetics. We were talking about the 30-year-old lady. Catch her young. Start statins at that level. So
I would have some issues with that statement, except for diabetes. But I think that should be another discussion another day. Not today.
So these are kind of new
That was also
concepts.
the concept for the use of statin during pregnancy and postpartum breastfeeding as well, for the pack years as well, for 2 to 3 years pack years.
Right.
Iris.
So I think I'm really thankful to all of you panelists, Dr. Ravindra Prabhu, Dr. Devendra Sannal, Dr. Priyamvada Tyagi, Dr. Shirish Sathe, and Dr. Arun Chopra for wonderfully elucidating the various nuances of the use of statins. And very thankful to our audience this evening who kept us busy with their very interesting and probing questions. So I apologize if we have not been able to cover all the queries that they had, but it's been a wonderful learning experience. Statins are very important and useful, and I find it relatively easy to use. For example, when we treat someone with type 2 diabetes, we have 3 main sort of areas to address. One is the hyperglycemia, which I find the most difficult to address. Then is hypertension, which is somewhat in between. And I find the use of statins or the lipid component most of the time is relatively easy to address. But they have their own issues, problems, which dose, when to use, what happens in CKD. So our panelists have done great justice. Thank you, all of you, this evening. And I would once again like to thank Intas for their perseverance with this set of endocrine talk shows. And this evening, the updated number last time I got was 1,300 doctors had joined. Do we have any others? So it's back to Intas for the final comments.
I think, sir, the number has swelled up to 1,400, more than 1,400 now, sir. So thank you very much once again, sir, for your presence on this program and platform. I think you have been a guiding force for Endocrine Talk Show for now over 3 years. We started this as a practice pulse in endocrinology. That was a didactic lecture show. And for last 1 year or so, more than 1 year now, we are doing Endocrine Talk Show, which basically brings up the issues related to endocrinology. We have been talking about disease for last so many programs. And last time when I was discussing with you, I put up this idea that can we review some drugs, and statins being such an old drug, they were introduced in mid 90s, and now we are in the 2023, more than 25 years of statins in the world, and yet there is so much of discussion on these wonderful drugs. And I think the kind of issues which were raised and the questions were raised and the answer which came, this discussion was very intriguing, and I'm sure all the people who logged in today, they really enjoyed the discussion, and they must have taken a lot of points back home. So thank you very much to you, sir, for being the guiding force. And I would like to thank the faculty for the program tonight, Dr. Arun Chopra, Dr. Shirish Sathe, Dr. Ravindra Prabhu, Dr. Priyambada, Dr. Devmalya Sanyal, who have been, I have been discussing with him for many programs. So finally, I could get him on this program. So thank you very much, Dr. Devmalya. And thank you very much for being on this show. And I must thank all the participants tonight, more than 1,400 or so, who must have got enriching experience of joining this program. So thank you very much once again from here at Intas. I would like to thank my entire team, the technical team who did this program seamlessly. Thank you very much once again, and good night to all of you for being here on this platform tonight. Thank you. Goodbye.
Thank you. Good night, sir.